Automatic implantable defibrillator. The automatic implantable defibrillator is a device that delivers electric shocks directly to the heart muscle defibrillation in order to terminate lethal dysarrhythmias, ventricular fibrillation, and ventricular tachycardia. The automatic implantable defibrillator is surgically placed by one of four approaches: lateral thoracotomy, median sternotomy in conjunction with cardiac surgery. Third one is subxiphoid or subintercostal. Design: the implantable defibrillator is slightly larger than pacemaker and consists of two component parts. One is pulse generator, contains the circuitry and battery to detect dysarrhythmias and generate the electric shock. The generator is placed in a subcutaneous pocket in the upper abdominal quadrant. Battery life depends on usage. Longevity is estimated at 12 to 24 months or 100 shocks. The direct current electric shock delivered is 25 to 32 joules. Second one, lead system. Two sets of leads are used and can be placed in various positions on or in the heart. One set of lead electrodes senses lethal dysarrhythmias in the heart. The other set of lead electrodes transmits the electric shock from the pulse generator to the heart. The implantable defibrillator is non-invasively turned on and off by a donut-shaped magnet. Function: 4 electric shocks are delivered in a programmed sequence. The device allows 10 to 35 seconds to detect the lethal arrhythmias, dysarrhythmia, charge, and defibrillation in the heart. The lethal dysarrhythmia must meet two programmed criteria: rate and amount of time spent from the isoelectric line to trigger the device to emit an initial electric shock. The amount of joules necessary to convert each patient is determined during insertion and testing of the device, usually 15 to 25 joules. Non-termination of the lethal dysarrhythmia by the initial shock triggers the device to continue the sequence, detect, charge, and defibrillate until a total of 4 or 5 shocks have been delivered. Number of shocks depends on device model implanted. Subsequent shocks are slightly higher at 30 to 32 joules. The total sequence lasts approximately 2 minutes. Non-termination of the lethal dysarrhythmia after the shock sequence signals the device to revert to the detection mode of operation and not to reinitiate the shocking sequence. The device will reinitiate the shocking sequence only if the rhythm other than the lethal dysarrhythmia is detected and maintained for at least 35 seconds. If this criterion is met and another lethal dysarrhythmia is detected, the device will cycle through the shocking sequence again. Termination of the lethal dysarrhythmia at any time during the shocking sequence signals the device to interrupt the sequence, return to a detection mode, and reinitiate the shocking sequence if another lethal dysarrhythmia is detected. Indications: failure of maximal conventional medical therapy to control ventricular fibrillation and or ventricular tachycardia as determined by electrophysiology studies. Survival of one episode of sudden cardiac death not associated with acute MI. Complications: infection, bleeding, device failure, pacemaker interaction, constrictive pericarditis. Thank you.